I'm going to ask a couple of questions, take chairman's liberty here. I hear a lot of patients telling me that they think, or they're under the impression that glucose feeds the cancer. I hear that a lot in my practice. The body is set up for the brain and the heart that lives off glucose for the liver to make enough blood sugar for the brain and the heart. So how much extra sugar you eat in your diet probably may go to fat if you don't burn it off. So the question that I come about, that people tell me that the keto diet allows them to feel better, less inflammatory cytokines potentially, maybe control weight. But the concern is, do the keto acids that are caused by this, do they cause any damage to the kidney? Or the protein that's substituted for the carbs, does that cause any kidney damage? So I'll let Leanne get her take on the keto diet in patients with carcinoma syndrome.
I'm not a fan. I've spoke to a few of it this week. The body really needs to have carbohydrates as its energy source. Usually you can consume 15 to 30 grams with your meal, and that's sufficient. But ketone burning or ketone diet is for short acting and for weight loss can also cause muscle mass loss, and we never want to lose protein from muscle mass while we're doing that. And from experience, because I go back to way back when we had Medifast and other types of diets that we really had a lot of experience with, and the rebound back is usually very quick. It has a success rate of less than 5% at 1 year, and it can cause what we call a yo-yo effect. You do it that time, the next you get off of it, and the next time you gain weight back faster. So it's really not something, and I don't think it's safe for kidneys. I think that probably somebody else can. Okay,
that's pretty much mainstream dietitian health assistance. Okay, Leanne, what role do acidic foods such as lemon and grapefruit play in assisting digestion of fats in the person who does not have a gallbladder?
I don't know that it will help a tremendous amount. It's a good flavor, but I don't know that it'll help. There are digestive enzymes in the market that are papaya-based, and those are very beneficial.
Are there any other foods that will help with digestion, absorption of fats in the absence of a gallbladder?
Medication that you can take and be ordered, the cholesterol.
Food. She's asked this question's about foods.
Foods, just stay away from the fatty foods and the spicy foods is probably the best advice for that.
What's the best diet to avoid diabetes if you have a subtotal distal pancreatectomy?
Well, foods aren't going to make you avoid it. If you control your concentrated sweets and sugars and you use complex carbs or carbohydrates evened out, you will not increase your glucose as fast, and that would be the most important thing.
Only a low-carb, high-fiber diet is enough?
Remember that again.
Yeah, only a low-carb, high-fiber diet is enough is a question.
Not low carb. I don't go lower than 30 grams usually with patients. And it can go up as high as 60 grams in men.
To get nutrients from fibrous vegetables, is it acceptable to juice them? Example, kale.
Yeah, I'm really fine with juicing as long as you don't use a sugar base and you're not using just all greens and don't use beet greens at all. They can be toxic.
What's your opinion of bone broth for added protein?
Any broth. I think that those can be beneficial. I don't think you can get enough protein to replace a meat with, but it's definitely something that's acceptable.
Okay, that's all the dietitian questions. We're going to turn one to cannabis. Where are we at research on cannabis as treatment for neck? And I say we're nowhere. Okay. Dr. Sue O'Drisio has been pimped with her questions. The first one is with respect to development of the future oncotest. Do you know anyone in the U.S. familiar with a genetic blood test marketed by the RGCC lab in Greece?
The answer is no, I don't.
Will a cytokine blood panel for autoinflammatory disease help with diagnosis for gene mutation?
No, it measures the proteins in autoimmune disease, but it does not tell whether, unless you had a complete absence of a cytokine that's normal, it would not help you.
Have you seen any correlation between families that have autoimmune deficiencies and its relevance or probability of net occurrence?
The best example of that I can tell you about is the findings are very important that type 1 diabetes may be an autoimmune disease. And the association I showed you between diabetes and a little bit higher risk for neuroendocrine tumors is the only association I know, and it's an association. It's definitely not a cause and effect.
If you have a child diagnosed with PNET at 25 years old and you have symptoms similar to NETs and traits of MEN1 and an elevated CGA tumor marker test, can a genetic counselor rule out MEN1 or NETs with a calcium test alone? Example, normal calcium level in a 49-year-old.
Well, the test that would usually be done in terms of chromogranin A, the first question you have to ask is, are they on a proton pump inhibitor? Because we know that increases the chromogranin A, and I've seen in children even a chromogranin A as high as almost 1,000. That went back to normal when I got them off of PPI.
I would just add to that, with multiple endocrine neoplasia, the rule usually is that over 90% will present with hypercalcemia. The first gland usually to be involved in a true MEN1 family is the parathyroid with hypercalcemia. That doesn't always obtain, and the question of just a CGA is, as Sue said, you have to be suspect because CGA is a little crude. It can be very helpful when you're following someone you know has a tumor in a serial fashion, but clearly the PPIs, even some people are very sensitive. Even a week's worth of PPIs can turn on gastrin and chromogranin A. And the way to, get around that is if you can stop the PPIs, such as omeprazole or Prilosec or Acifex or Protonix or Nexium over the counter. There's so many of them now that it's easy to just take them for a week or two and then, kind of forget you've done it. So CGA in and of itself, I don't know if that would call in an menin test for MEN1, but you need to be a bit cautious on that.
In terms of MEN1 and children being tested, the recommendation actually by the genetic counselors is that we don't test, even if we know the gene is in the family, until we see an elevated calcium. Now, having said that, my biggest problem in a couple of families was that I couldn't get the family to bring the kids back in when I thought we were ready for testing. So I think, it's important to know if you have MEN syndrome, to know what mutation you have, so that it's much easier to follow the children.
Can NETs cause high or low blood pressure, Tom?
So both. The carcinoid is the best example of the carcinoid tumor. 51% of true carcinoid tumor patients may be hypertensive, episodic hypertension. However, when the serotonin starts to go high and is sustained, then you're prone to dramatic drops in blood pressure. I always say flushing of carcinoid is symptomatic, and so patients will have fainting or feeling lightheaded and have ringing in their ears, and that's because of pulsation of serotonin. When serotonin is kind of high and then shoots high with excitement or exercise, it can cause a physical drop in blood pressure because it's a powerful peripheral vasodilator. So it's very possible. Now, clearly, a functional pancreatic tumor making VIP in general causes a very dramatic drop in blood pressure. It goes down, not up. Catecholamines, norepinephrine, by its nature, causes hypertension. So symptomatic pheochromocytomas or paraganglioneuromas will often cause high blood pressure, and that can be caught with biochemical testing of norepinephrine in the bloodstream.
I've been on Sandostatin 30 milligrams LAR every 14 days since 2002 and needed Creon at the start. 5 or 6 years ago, or 10 years of treatment, I no longer need Creon. What might this be?
So what you get with octreotide, and especially the LAR and lanreotide depot, as we heard, is a suppression of pancreatic enzymes when you eat. Well, I have seen several people on that dose that undereat the fat malabsorption. So they simply don't take in that much in a major meal that they would have the symptomatic, but they're few and far between. I don't know if that person's living by themselves or not to verify that they're not having subclinical fat malabsorption, because it's a very odorous, distinct smell. Lowell can share his observations, but I have never seen anybody adjust. The best study that was done was 25 years ago, when people took subcutaneous octreotide. They had they had an increase in their fat in their stool, and then over time it came back toward normal, but never reached normal. And that was after 12 to 14 weeks. So it's possible to undereat that. So if you don't take a lot of fat in your meal, you can stay below that threshold for fat malabsorption.
Yeah, I would concur with that. One question I have about Carson heart disease, Tom, do you think that the incidence of Carson heart disease is changing any since we've had more modern therapies,
Yeah, that's a great question, because I think the first paper that was alluded to today divided the heart disease into group A, B, and C. And those were done through periods of time. Now, this one that she showed started in, I think, 1984 or 85. Octreotide came out in 1989, but it clearly probably had an impact on the development of right-sided heart disease when octreotide started to come into the country and was really peaking in its use for carcinoid tumors. Is that its serotonin is probably the primary culprit of the right-sided tricuspid and pulmonary valve disease. And that's because the liver, and Dr. Dillon also alluded to the fact that you can have carcinoid syndrome without having a liver full of tumor, but the liver, when it is producing serotonin in high amounts, impacts the right side of the heart. Substance P has also been implicated, but it's never been easily shown because it's very difficult to measure in the blood. But substance P probably augments the action of serotonin. But the occurrence, the onset of the use of octreotide clearly had impacted, and in fact, by the time they got to group C in the first Mayo paper, they had fewer cases per year. And that was one of the biggest, most striking. They said that because they had early surgery, they did better. And I think later on they acknowledged that probably the use of octreotide was impacting the incidence of heart disease by the time that group C, which was the more current years. So I would clearly think octreotide has impacted because it has antagonized. Remember, that was brought up today. Octreotide does two things. It inhibits release of the hormone from the cell, and it's an anti-proliferative, but it also blocks the action of the hormone on its target tissue. In the case of the valve, it's serotonin's action on the valve that's protected by octreotide.
What would left side carcinoid heart be more dominant in lung nodes?
It tends to be because with the return on the pulmonary side goes to the left side of the heart. You can see left-sided heart disease in otherwise regular right-sided valve disease if you have what they call a foramen ovale, a patent foramen. So there's a little opening when we're born between the two chambers of the upper heart. And when that stays open, you can cause mitral valve damage because the serotonin is coming through the chambers. And that's a very small percent. For the most part, carcinoid heart disease is really tricuspid first and then the pulmonic. But you can see left-sided heart disease. And with the lung, you are impacting the left side of the valve more than the right side, because that's the way the effluent from the lung takes the blood to the left side of the heart, oxygenated.
What kind of echocardiogram necessary? Regular, stress, or transesophageal?
So I think regular echo, transthoracic across the chest, it works very well. Sometimes they have to do more detailed where they'll do a transesophageal because of the tilt of the heart. But in general, a regular transthoracic across the chest is more than adequate.
Do you ever see tricuspid heart damage in valves of neuroendocrine tumor patients with a non-functioning PNET? So this would mean that.
So unless the PNET is making high levels of serotonin, and there are some reports now coming out that we in general don't see those higher levels in the PNETs. There can be true pancreatic carcinoid. They run about 0.5%. For the most part, these aren't really carcinoids of the pancreas, as was brought up earlier in the talks, but these are neuroendocrine tumors of the pancreas. I personally don't think I've seen a PNET with right-sided valve disease. I just haven't.
And how many thousands? Out of how many thousands?
we have quite a few.
This one, for examining the heart for carcinoid injuries, is an MRI or CT better?
Try that.
I think generally an MR would be more sensitive if they're thinking surgery or such. But when I've had patients with metastases to the heart, they usually get an MRI to look at quantitation.
That's what I was thinking.
They can measure the grams of tumor in the heart with MR.
Yeah. And you can do that as well, but the MR is very helpful for lesions. There can be lesions in the heart, and those are important to follow for size and maybe anything from the floor. Let's see. Excess fluid. I'm not so good at that. I don't think so. I'm going to pause on one heart one.
So there's two questions for Dr. Connolly who's obviously not here, we'll pose on. So I guess this becomes the portion.
Any questions maybe from the floor?
We've got a few extra minutes here. Closing remarks, I guess.
There's a question back here. Good. Go ahead. Hold on, we're getting the microphone. There you go.
Thank you, young lady.
Thank you. Is right-sided heart disease the same thing as pulmonary hypertension?
Can be. Right, because that's what you want to avoid. The complications of right-sided pulmonary hypertension can result from severe right-sided heart disease. Good question.
Any other questions from the floor?
There's one back there.
I want to thank everybody for their attention for this segment. And I guess we're moving into the closing remarks.
That's what you did,
I think
One more
that
question.
Dr. Wolin said something about probably sandostatin has been shown to maybe have some application for gallstones. Would that also be true for kidney stones?
No.
No.
No?
But it's very true for, as Dr. Wolin said, for gallstones, because one of the mechanisms of octreotide and lanreotide is to inhibit the contraction of the gallbladder during a meal. The gallbladder stores bile so that when you have a meal, it squeezes and goes down into the intestine. Octreotide and lanreotide paralyze the release of a hormone called cholecystokinin. And when cholecystokinin is paralyzed, it can't squeeze the gallbladder during a meal. But as far as I know, there's no, and that's been a good question in the past, I don't know of it having any problem, anything to do with renal stones. Yes? Another question?
For Leanne, do you have any thoughts as to why so many people have problems with tomatoes and anything with tomatoes, from tomatoes, ketchup, spaghetti sauce? I'm going to add to that also dairy when it's not a lactose problem. So two different questions there.
Tomatoes are a high source of histamine, and these tumors release histamine. Many times it's the histamine that's not tolerated in the tomatoes and tomato paste more than than the tryptophanes. And dairy is if it's not a low fat for the milk, it can be just the fat content of the milk that you're not tolerating. If you go down to skim and can tolerate it, then you know it's that. And there's some people that just don't tolerate milk, the dairy, the milk itself, the casein.
I think we have time for two more questions. Something over here.
This is for Dr. Sue. My daughter had a carcinoid tumor in her appendix about 20 years ago when she was in college. If I'm remembering right, it was like 0.4 centimeters, but how would it be best to try to follow her since I'm a patient now? And is that considered midgut also?
So yes, appendiceal is considered a midgut. But your father was how old? 10 years old? She was 20 years old when she had it?
Oh, sorry about that.
Yeah, sorry. Yes, she was about 20. She was, I think, a sophomore in college.
Okay. So that depends very much on the size of the tumor and whether it had evaded outside the appendix. The older you get when you have an appendiceal carcinoid, the more careful you need to be about being followed up. The literature out there in children under the age of 18 is that it's an extremely low, like less than 1% of those go on to be metastatic. I usually follow in those young people I follow them for 2 to 3 years just with biomarkers. But the older they become, the more likely it is to be able to become metastatic. And many times what happens even in that age is they're done laparoscopically and nobody looks at whether there are any lymph nodes involved. So that's the caution I would say.
Okay, I have a question over here.
I know that one of you said that sandostatin reduces hormones, so if they suppress insulin, would it be best to just take the 30 milligrams of sandostatin rather than the 60 so that you don't become diabetic?
So that's a good question, and one of the things that happens if you go back 200 million years at the hagfish and you look at insulin secretion, and next to it is somatostatin secretion. And if you look now at the octreotide and how it inhibits, it has a predilection not to inhibit insulin. So it inhibits other hormones preferentially to insulin. Having said that, the higher doses you suggest, 60 milligrams, is enough to probably impact the receptor that controls insulin inhibition, and that can, and it's especially more, I guess it's a little bit more obvious with the lanreotide because it has a little more predilection to that other somatostatin receptor, not receptor 2, but receptor 5. The other question you raised, though, is what does 60 milligrams over time? You know, there's a lot of early literature that showed that the LAR, you may downregulate. It may become insensitive to that. I personally haven't seen de novo diabetes, new onset diabetes, unless a person was very prone to it by familial type 2, but I have not seen full-formed diabetes with octreotide, and I just haven't seen it. You can get glucose intolerant, and Lowell has probably a very big experience, and so I'm sure Ed and Dr. Dillon, but I just haven't seen de novo.
That's been my experience too. So if someone has a tendency to become diabetic or has elevated blood sugars, then you start them on the somatostatin analogs, it'll go up a little bit. So any anti-diabetic meds would have to be adjusted accordingly.
Okay, we have one final question, and then we'll ask for final thoughts from the panel.
I'm curious what the vagus nerve does and what problems can happen from having it cut, say during a multivisceral transplant.
I didn't hear the question. Did you hear the question? I didn't hear that question well. I'm sorry.
I'm asking about the vagus nerve.
Oh.
What does it do, and what problems can arise from cutting it, say, for example, during a multivisceral transplant?
So it's a good question. Dr. Howe could probably talk about it better than anybody. Vagotomy was used and pyloroplasty was used to cut acid secretion. Do you want to comment on that, Jim, in terms of action?
Well, yeah, I mean, it'll have an effect on GI motility because the vagus stimulates motility and gastric acid secretion. But you can get by with cutting the trunks of the vagus. We used to do it all the time. We don't really do it anymore, but for acid reducing surgeries, it used to be done quite often.
All right, well, any final thoughts?
I just want to congratulate you all on how many of you stayed to the end. I can tell you that wouldn't happen at a scientific meeting.
And I too want to thank you and say I probably learned as much as anyone in the room listening to the talks. I thought they were great talks and very applicable.
Yes, I want to thank you again for having me, and it was a wonderful audience, and you've been a great group to be with for the last couple of days, and we hope that you continue to be very involved with support groups in your areas and share your information that you have available after this great conference. Thank you again.
And I'd like to extend appreciation to the Waymans for coordinating all of this. I think they've done a phenomenal job. It seems like each one of them gets better and better. And I think that's simply because we get smarter and smarter and there's more and more options. So to me, we've made a lot of progress over the years. So it's my thanks to them for taking this on. It's a huge endeavor. And I know that there's a lot of anxiety and angst involved in every bit of it. So my hat's off to them, and I wish them great future effort and support in going forward.
Well, Very good. I'd like to give everybody a round of applause, yourself.